नहीं उनको मैंने फोन लगाया उठाई नहीं डन
स्टार्ट करूं? Hello, check. All right, good evening, students. This is Dr. Kunaal Agrawal, your original guru for the subject of orthodontics and dentofacial orthopedics at DBMCI MDS. So, today we are gathered here to discuss about the most important topics which are expected for INI-CET MDS 2024 November session examination. I hope all of you are keeping well. I hope all of you are studying well, taking good night rest because this is the changing season and this is the season of dengue, chikungunya, malaria. So I just hope you people take good care of yourself, stay hydrated, drink plenty of fluids, drink plenty of water, right? So in this particular session, I'll be talking about the main topics which are usually asked in such exams and related subtopics of that particular unit in the subject of orthodontics. So starting with the first unit, that is growth and development. This is an important unit, as you can have many questions on this particular topic. You will have application based MCQs on Scammons growth curve, several called rate of growth, then synchondrosis, primary cartilage, secondary cartilage, the direction of growth vector of nasomaxillary complex, the direction of growth vector of the basic occiput, the base of the cranium, which is upward and forward, whereas that of the nasomaxillary complex is downwards and forwards because of primary and secondary displacement. I hope you people remember that. Then what are the bones formed by endochondral and intramembranous ossification in head and neck region? You should be well versed with the bones which are formed by endochondral ossification, the process behind it, the biological principles behind the ossification of bone. So all those conditions, all those topics you have to be well versed with. Then, as I said, the difference between primary and secondary cartilage, the the histological sections of primary and secondary cartilage, you might get certain image-based questions pertaining to this. Then theories of growth, especially the functional matrix theory, and also the functional matrix theory revisited, because recently only I was just going through and I just saw a question which particularly asked about the functional matrix theory revisited in a twisted manner. We have talked about functional matrix theory revisited elsewhere, so I'm not going to repeat it here again. Then many questions you can expect from postnatal growth of maxilla and the mandible, especially the application based questions. I have an application based question for you just after this slide, so just give me a moment. And finally, Enlow's V principle of growth. How is it different from other principles of growth? Which bones are there to exemplify this particular principle of growth? The mandible being the most commonly asked bone. Then we talk about the coronoid process, the palate, etc. Now this is one MCQ. It's an application based question. You have to apply your mind here. So question is, a needle fragment embedded in the anterior border of the ramus of mandible of a 6-year-old child would. So anterior border of the ramus of a 6-year-old child. So I suppose the needle must be inserted somewhere over here. The violet colored needle, no? Now as the child grows in age, so does the mandible in both anteroposterior plane, vertical plane, and transverse plane, right? So as the mandible grows in the anteroposterior plane to make space for the not yet erupted second, third molars, in that case, the posterior surface, the posterior border of the ramus, which was posteriorly placed once upon a time, has now become the anterior surface of the ramus of the mandible, or the anterior border of the ramus of the mandible. So if you look at the question very carefully, if you visualize the question very carefully, you can very well answer that the needle which was inserted here at 6 years of age, now suppose the patient the child has become 15 years of age. After 9 years, you will observe that the needle has become free and it has inserted into the soft tissue as resorption uncovers it. This is one example of an application based question. So exam setters are going to ask you such questions to understand how well deeply you have understood the concept behind that particular topic, and also how well properly you can apply that question, you can apply that concept into the question asked. That is a primary objective any exam setter is going to expect rather from you. Okay. Another image based question, not an image based question, rather another application based question from Scammann's growth curve. Which of the following statements is false about Scammann's growth curve? Neural tissue, most of the growth is completed by 6 years. This is true. Lymphoid tissue, the growth reaches 200% by age 13 and represses afterwards. This is also true. The genital tissue, most of the growth is completed by the age of puberty. This is absolutely false, because most of the growth of the genital tissue starts by the time the patient has reached puberty, and different tissues grow at different rates. This is also true. So which one is false? Option C is false in this particular case. Next topic of interest is development of dentition and occlusion. Again an important concept, again an important chapter to be understood. You will have clinical application based MCQs on leeway space of Nance. So you have to remember the different values. The leeway space of Nance is for the late mesial shift. For the maxilla it is different, for the mandible it is different. For the maxilla it is 0.9 millimeter per side. That makes a total of 1.8 millimeter. Whereas for the mandible it is 1.7 millimeter per side. That makes a total of 3.4 millimeter on both sides. So questions like that. This is an example of a direct memory based question. You just have to remember the values and that's it. That is just a small example. But the story goes beyond this. You will have image based questions. You will have application based questions from leeway space of Nance. You will have questions on the early mesial shift, the late mesial shift, the factors surrounding that particular developmental phenomena. Okay. Then anthropoid semen spaces. For the upper teeth, it is present where? Just mesial to the canine. Whereas for the lower teeth, it is present just distal to the primary canine. Remember that. Ugly duckling stage, also called broadband phenomena, also called as median physiologic diastema or physiological median diastema. So you will be asked questions like a patient, the parents of a patient who are concerned give you a visit regarding the development of midline diastema between the teeth of their 10 years old child. You have to focus on the age of the patient, 10 years old child, because that's the time when the maxillary canines usually erupt. And when the canine are in the eruptive stage, you will see the ugly duckling stage. So question will be like that. What is the next line of treatment? So does the patient require orthodontic treatment at this particular point of time? No. Why? Because it's a self-correcting anomaly. You just have to reassure the patient, you have to reassure the parents rather, that this condition, this is a transient phenomena, it is a developmental phenomena. Or you can even explain how the maxillary canines, which were once almost in a horizontal fashion, they change their inclination and then they erupt in a vertical dimension. They erupt in the vertical plane of space parallel to the adjacent teeth. So things like that, questions like that can be asked to you. Then I told about early and late mesial shift. Then dental versus chronological age of development. Questions can be asked. You can be given image based questions, or you have to remember the sequence of eruption of the teeth and the age at which a particular tooth erupts for the maxillary teeth as well as for the mandibular teeth. You can be asked questions like the most common cause of buccal placement or buccal how do I say the buccal movement of the premolar. or the buccal movement of the canine could be because of, suppose a maxillary canine is buccally placed. It is high placed in the vestibule, but it is placed in the buccal direction. What can be the cause of this? It could be, the primary cause could be the arch length deficiency. But what about if a maxillary canine is placed palatally, or if it is impacted palatally altogether? The cause could be either a congenitally absent maxillary lateral incisor or a morphologically different lateral incisor, example, peg-shaped lateral. Now the theory goes behind this. There's something called eruption guidance theory, which was given by Stella Chauchu and Adrian Becker. So what does this say? This theory says that the distal surface, let me draw a diagram. This is the lateral incisor. It says that the distal surface of the lateral incisor, it forms a guide plane. It forms a guide plane which guides the proper eruption of the maxillary canine. In the absence of which, the guidance is gone, and the teeth have a 99% chance of getting impacted either palatally, or there are 99% chance that the teeth, although not impacted, but it can be placed palatally in a cross-bite condition. Okay, so questions like that. Then you will be asked questions about functional occlusion, mutually protected occlusion, and MCQs on TMJ, physiology, anatomy, and one more thing I'll add here, evolution of TMJ. So what kind of a joint is TMJ? That is a gingilimo diarthrodial joint. That's the only joint in the entire human body which falls under the classification of gingilimo diarthrodial joint. Such a unique joint that is. So you will be asked questions about the movements of the temporomandibular joint, which we have already discussed. We have the hinge movement up to certain extent, then the horizontal axis of, it was initially placed here, intercondylar axis, then up to certain extent, up to 10 or 20 degrees opening of the mandible, the axis shifts downwards at the mandibular foramen, and the anatomy of the temporomandibular joint, the glenoid fossa, is such that it leads to translation of the mandible forward, and hence the pure hinge movement converts into a translative movement of the mandible. So questions like that you will be asked. Okay. One question: the loss of primary first and second molars in the same quadrant in the early transitional dentition can cause an arch perimeter deficiency. In addition to this, additional problems can include shift of the mandibular midline to the affected side, supra-eruption of the premolar in the extraction area relative to the contralateral premolar, shift of the mandible to the opposite side upon closure due to the dental movement of the primary canine on the affected side, or extrusion of the opposing primary molar. So the question is asking the loss of the primary first and second molars in the same quadrant in the early transitional dentition can cause an arch perimeter deficiency. Other than that, it can lead to extrusion of the opposing primary molars because the antagonist tooth is lost, and once that is lost, because of the eruption forces, because of the eruptive forces generated in the PDL of the teeth, that is an ongoing phenomenon, no? So it's only the antagonist tooth which stops the over eruption of the tooth, in the absence of which the eruption process continues to happen, and that can lead to super eruption of the antagonist tooth. So that's why option D will be the correct answer. Next, etiology and classification of malocclusion. So these topics, what I'm talking about, these topics fall under the theoretical concepts of orthodontic treatment. But as we go further and things start to become more interesting, we'll be talking about certain clinical topics also. So in this particular chapter, you'll be asked about reverse classification of etiology of malocclusion and related application-based questions, hereditary general and local factors, again application based questions. Now one doubt I was asked by certain students maybe few months back, if I remember correctly. The doubt was, which type of malocclusion has got more genetic predisposition, whether it is class 2 division 2 or class 3 malocclusion. So this was the most prevalent doubt I've encountered so far, and rightly so. I've looked into this. I've referred to certain topics, certain articles, certain international articles, from British Journal of Orthodontics, from American Journal of Orthodontics, Angles Orthodontics. One article I've come across, which was authored by Mosse, I think in the year 1999, if I'm not wrong, in British Journal of Orthodontics. According to this particular article, it's class 2 division 2 malocclusion has a more genetic predisposition than class 3. Both are genetically determined, but out of the two, class 2 division 2 malocclusion has a more genetic prevalence as compared to class 3. Please remember this, okay? Now you will be asked application based questions on angles classification, premolar classification, Ackermann profit classification, and modifications of angles classification of malocclusion. So that includes Simon's classification or canine law, that includes the cat's premolar classification, and then also it can also include the latest additions to Ackermann profit system of classification, that is yaw, roll and pitch, roll and yaw, no? So what do you mean by yaw? Okay, what do you mean by pitch? That is up and down, that is in the transverse plane of space. You can have vertical maxillary deficiency, vertical maxillary excess, which is seen along the vertical plane of space, that is called pitch. Roll means canting of occlusion, that is called roll. And yaw means any deviation in the transverse plane of space. Means if the mandible is moved on one side, either on the right side or the left side, that is called yaw. This is the latest addition to the Ackermann profit system of classification. You should be knowing that, okay? Then clinical features of class 1, class 2, division 1 and 2 and class 3 malocclusions. Not only clinical features, you will be asked application based question like this. You will be given certain clinical based scenario questions, like for an example, you will be given a patient, you will be given the age of the patient, for example late mixed dentition, around 7-8 years of age, or 10 to 12 years of age, that is late mixed dentition period. You come across a patient having a class 2 malocclusion with mandible retronatism. What will be the correct treatment of choice? So if all the parameters of the question are given, and in most probability the answer will be functional appliance treatment. Okay, so questions like that. An index of orthodontic treatment needs. There are many indices available, many indices popularized, but the index of orthodontic treatment needs having two components, the dental health component and the aesthetic component. These two are important. You are not supposed to remember each and everything. There are 5 grades in the dental health component of IOTN. You are supposed to remember grade 3, grade 4 and grade 5. That's how the severity of malocclusion goes, no? If a patient has a grade 5, so that is where the requirement of orthodontic treatment is at its peak. Whereas grade 1, that means minimal or hardly any treatment is required. So as you deviate away from grade 1 and go up to grade 5, the complexity of malocclusion increases, and so does the complexity of orthodontic treatment required also increases. Okay. Increased column angle is seen in which of the following malocclusion? I put an MCQ for your just for a reference. particularly for this particular topic. Now, what is column angle? What is column angle? This is the long axis of the tooth. We are talking about upper central incisor. We divide the crown and root into two parts. The long axis of the crown and the long axis of the root. In normal cases, this is how the tooth is. But in class 2 division 2, you know the clinical feature of class 2 division 2? The central incisors are retroclined. So, during development, what happens? The long axis of the root and the long axis of the crown. This angle is called column angle. This complementary angle is known as column angle. So just compare the two angles here. This is a normal class 1 malocclusion, class 1 or class 2 division 1 malocclusion, whereas this is class 2 division 2 malocclusion tooth. Compare the column angle between the two. So without any doubt, it is increased in class 2 division 2 malocclusion. Okay. One more example, a flat, low-lying, anteriorly placed tongue is one of the factors in the development of. Now this particular question is from the etiology of malocclusion. I told you about earlier, no? A flat, low-lying, anteriorly placed tongue is one of the factors in the development of class 3 malocclusion. So naturally, if the tongue is placed low, flat and anteriorly placed, that is going to push the mandible forward. Right? That is why it is going to create prognathic mandible, leading to development of skeletal class 3 malocclusion. Next is orthodontic cephalometry. Again, an important concept. Conceptual based questions will be asked from this particular topic. Conceptual, direct questions, indirect questions, application based questions, everything. So you have to understand the science behind orthodontic cephalometry, the armamentarium used, the inventors, the researchers who invented this particular technique, Broadband and Hofrath. Broadband was in USA, Hofrath was in Germany, and incidentally both of them created this technology simultaneously in the same year. That is why the credit of development of orthodontic cephalometry goes to both. Then landmarks. You will be given picture-based MCQs, image-based questions will be asked. You have to identify which landmark is where, which is the most stable landmark, which landmark is difficult to intercept, which is difficult to mark on the cephalogram, questions like that. We have talked about all the landmarks in my recorded and live lectures. I hope you are well aware of them. Then clinical applications of mathematical, numerical, angular and linear measurements of various cephalometric analysis will be asked. You will be given questions like, I have few questions just after this particular slide. You will be given questions like the growth axis angle is this, or you can say the mandibular plane angle is this, or the incisor mandibular plane angle is this. You have to determine the prognosis of the tooth. You have to determine the growth pattern of the patient, related prognosis, related treatment mechanics, and then you have to answer the question whatever has been asked in the particular question. Okay. Then little bit about superimpositions can be done, although not very important, but still. Then visualize the clinical scenario before attempting any question. Now this particular line I have particularly mentioned here because I want to emphasize on this particular topic, on this particular line. I have always been telling you since I have started teaching to all of my students that whenever a question is asked, whenever a clinical application based question is asked, they can be the most easiest to attempt, or they can be a nightmare for you also. It all depends upon how you approach that particular question. So my advice, I have followed the same. My seniors told me about how to attempt such questions. The same advice I am giving to you. If you encounter any clinical based questions specifically regarding orthodontic cephalometry, pause for a moment. You are given rough space. You are given rough space in your answer booklet, no? Even though nowadays everything is online, still you will be given certain pen and paper, pencil paper in your exam center. So try to draw whatever is asked in the exam on a piece of paper. Try to visualize what the question is asking. Try to make that answer. Try to form an answer in your mind. And then look at the MCQ. Look at the options available. Because this is a sure shot technique. In 99% of the cases, your gut feeling is the right answer. Okay? So trust me when I say this. I have followed this particular technique myself. I have always advocated this technique to all of my students since the beginning. So if you want to follow, please take this advice from me. All right. Example and MCQ was asked in INI-CET May 2024. Facial angle indicates. Now what is facial angle? What is facial angle? Facial angle is the angular relationship between the Frankfurt horizontal plane and facial plane. Facial plane is a line joining the nasion to the pogonion. So this angle, particular angle, is known as facial angle. So it indicates the relationship of mandible to the upper face, the relationship of the maxilla to the face, convexity of the face, or relationship of maxilla with the mandible. So now you have the diagram in front of you. You tell me what should be the answer. You tell me what should be the answer. Just a second. Let me open up my YouTube if I am encountering any question. One second. All right. So what should be the answer? The facial angle indicates the relationship of the mandible to the upper face. So I have one question. Can you please explain overjet and overbite? Anand Sinha has asked me to explain overjet and overbite. All right. So overjet is nothing but it's a horizontal or anteroposterior distance between the incisal edge of the upper and the lower central incisor. So this is the lower incisor, this is the upper incisor. The horizontal distance or the anteroposterior distance between them is known as overjet. Whereas overbite is the vertical overlap between the two incisors. So this much is the vertical overlap between the two incisors. That is called as overbite. That's in the vertical plane of space, and overjet is in the horizontal or anteroposterior plane of space. That's the primary difference between them. Okay. So facial angle indicates relationship of mandible to the upper face. One more, another important MCQ. Which of the following statements is false in relation to bird face deformity? Now, what is bird face deformity? I'm sure you are well aware of this particular phrase. It is used most commonly. You must have read that in the chapter on bone deformities or bone diseases in oral pathology. Now, bird face deformity is a term specifically used in patients suffering from TMJ ankylosis. So such a condition prevents the forward growth of the mandible. So the anteroposterior discrepancy is so severe, as you can see in this figure, that the maxilla is normally developed, but the mandible is so much back. So by looking at the patient's profile, it gives an appearance that patient is having a beak. That's why it's called a bird face deformity. So does it have, options are class 2 malocclusion, retrogenia, retrognathia, more FMPA, that means high FMPA, or more posterior facial height. So false statement out of them is more posterior facial height. What happens in bird face deformity? The posterior facial height is measured from sella to gonion. and antefacial height is measured from nasion to menton, right? So this such kind of patients have a severe vertical growth pattern, and whenever you have severe vertical growth pattern, the posterior facial height is very less than anterior facial height. So we have less posterior facial height in patients suffering from bird face deformity, not more posterior facial height. All right. Now this is a clinical question. A cephalogram of a 10-year-old child shows A and B of -4 degrees. A and B of -4 degree means it's class 3. The mandible is prognathic. And facial angle of 98 degrees. Now what is facial angle? I just told you. It shows the relationship of mandible to the upper face. If it is more than 90 degrees, that means it's a prognathic mandible. This case is of true class 3 malocclusion. So I have made the answer even before looking at the options, no? That is exactly what I was talking about. Once you encounter any clinical based question, visualize that particular question in your mind, frame an answer, then jump at looking at the options. You will succeed. I'm telling you, will succeed in that. All right. Next is diagnosis and treatment planning. Next chapter of importance is diagnosis and treatment planning. That includes both essential diagnostic aids, supplemental diagnostic aids, both. In essential diagnostic aids, case history, cephalic and facial indices, OPG, clinical study models and model analysis, these are important. Supplemental diagnostic aids include radiograph. I just told you about in the previous discussion. A little bit, 1 or 2 questions I've seen here and there from electromyography, EMG. So one particular question, and also you will be asked MCQs on certain facial asymmetries. Now particularly for electromyography, I have encountered one particular question. Let me remember, what was that exactly? All right, the question was, which particular malocclusion, or you can, the question was, let me remember, class 2 division 1 malocclusion. Class 2 division 1 malocclusion shows high electromyography activity of which particular muscle? Now for this you have to remember the clinical features associated with class 2 division 1. So one particular feature was lip trap. Lip trap or hyperactive mentalis muscle, no? So high electromyographic activity will be observed in the mentalis muscle. So that was the answer. That's how the exam setters are going to twist the question in order to test your clinical knowledge and your application based skills. That is what I'm talking about. Okay. So a 8 years old patient has good occlusion with full teeth present for that age. One of the central incisors is rotated with a large midline diastema. The most probable cause will be. Now 8 years old patient means the maxillary and mandibular central incisors have already erupted. That's a dental age, no? Now one of the central incisors is rotated with a large midline diastema. That is a clinical scenario which has been given to you. The most probable cause will be presence of a supernumerary tooth, thick labial frenum, thin labial frenum, or juvenile periodontitis. Whenever you encounter a patient having a rotated central incisor or an impacted central incisor, the first thing you should do is examine that patient radiographically. Occlusal radiograph, simple IOPA, or an OPG. But nowadays, with the advancement of certain techniques, you can even go for a CBCT analysis. So in most probability, in most cases, you will be seeing a presence of a supernumerary tooth, that is mesiodense, present between the central incisors, which is which is hindering the path of eruption of the central incisors. Okay, so rather than simply jumping at the conclusion, what conclusion? That a large midline diastema will require frenectomy. That is not so. You have to look at the clinical scenario presented to you. Again, you have to visualize and then answer. So presence of a supranumerative, that is mesiodense, in most likelihood is going to prevent the eruption of the tooth, or it can lead to certain rotation of the central incisor in most of the cases. An apparent unilateral crossbite involving the permanent maxillary first molar may be associated with. Now, an apparent unilateral crossbite. You can see in the particular figure, this patient has a unilateral crossbite on the left side, on the patient's left side. Involving the permanent maxillary first molar may be associated with a mandibular shift, a bilateral constriction of the maxilla, or correction of the maxillary arch with expansion, or all of the above. So pretty simple. Correct answer will be all of the above. Mandibular shift, why? The patient can resort to developing a convenience bite due to functional interferences. Right? So one side the patient is keeping the mandible for a constant for a long period of time. That becomes a habit. That becomes a convenient habit for the patient to chew only from one side, leaving the other side unattended, leading to development of a crossbite on the other side, leading to accentuation of crossbite on the other side rather. A bilateral constriction of the maxilla. Yes, maxilla can be constricted bilaterally. Again, the patient will engage into convenience bite. The side which is more convenient, the patient is going to shift the mandible on that particular side. That is called functional shift of the mandible, leading to development of crossbite on the other side, on the contralateral side. And the correction of an unilateral crossbite, always remember, the correction of a maxillary unilateral crossbite is always done using bilateral expansion of the maxilla, not unilateral expansion of the maxilla. So all of the above will be the correct answer in this particular question. Next is biomechanics of tooth movement. Now this again is a important topic. Sorry to say, I know many people do not like this topic. Even I did not like this topic back then, but nothing can be done. You have to remember certain concepts. You have to remember certain moment to force ratios, clinical based scenario. You have to remember the term center rotation, center resistance, moment couple. You have to know the difference between controlled and uncontrolled tipping. Torque is called inclination, and tipping of the teeth is known as angulation. So these two are the terms which many people get confused in. Then translation, bodily movement, magnitude of forces applied for specific types of tooth movement for intrusion, translation, tipping, torquing. One couple versus two couple systems. Application image based questions. We have talked about one couple, two couple system many times earlier. Moment to force and moment of couple ratios. So all these terms and all these clinical principles should be known, should be remembered by heart. So I have in particular involved this particular slide for you. So whenever we have moment to force ratio between 0 to 5:1, we have uncontrolled tipping. Whenever the moment of force ratio goes from 6 to 9:1, we have controlled tipping. Whenever it is 10:1, we have translation of bodily tooth movement. And whenever we intend to move the root, that is torque, the moment to force ratio should be more than 10 millimeters, or 10:1, sorry. That is one aspect. Now, second aspect is a ratio between the moment produced by the force applied to move a tooth, that is called the moment of force, and the counterbalancing moment produced by the couple used to control root position. That is called moment of couple. Okay, so the ratio between the moment of couple and moment of force determines the type of tooth movement what you intend to produce. Now, if the MC to MF ratio is 0, if the MC to MF ratio is 0, that means the tooth is going to undergo pure tipping. The tooth is going to undergo pure tipping. As the moment to force ratio increases, the center rotation is displaced further and further away from central resistance, producing what is called as controlled tipping. Okay, whenever moment to force ratio, whenever moment of couple to moment to force ratio reaches 1, the center rotation is displaced at infinity, and whenever the center rotation is displaced to infinity, the type of tooth movement what is obtained is called bodily movement or translation movement. And whenever the MC to MF ratio is more than 1, we will obtain root torque. So you have to remember this. This is important. Please remember this particular topic. This is a $1 million question. You will be asked, definitely you are going to be asked questions from this particular topic. So if you are still not able to understand this, I'll be very happy to assist you in understanding this topic. Even you can ask me personally on WhatsApp. I'll try to explain this even more in a better way if somebody is not able to understand. All right. Now, different force values for different type of tooth movements. For uncontrolled tipping, we have 35 to 60 grams. Controlled tipping, again 35 to 60 grams. Bodily tooth movements, 70 to 120 grams. Intrusion, 10 to 20 grams. Extrusion, root movement, rotation, and certain moment to force ratios. For uncontrolled tipping, we have 0 to 1 to 5:1, I told you. For controlled tipping, it's 6 to 7:1. For bodily movement, it's 10:1. And for root movement, it's 12 to 14:1. So we are supposed to remember this particular table. So one related question, the appropriate force tables for tipping a single rotated, okay, it should be single rotated anterior tooth lies between 30 to 50 gram according to this particular table on your left. A couple constitutes, what is a couple? It constitutes two equal parallel forces acting in the opposite direction. So that's an example of couple, that is non-collinear forces, equal but non-collinear forces acting in opposite direction lead to a tendency called rotation of that particular body around a particular axis in the center of the tooth. Biology of tooth movement, my favorite topic, but a nightmare for many of the students. Many things to remember in this: different theories of tooth movement, piezoelectricity, historical development and research behind orthodontic tooth movement, the bone bending theory, characteristics of piezoelectricity, pressure tension theory, the cellular and molecular mechanism behind orthodontic tooth movement. We have talked about this in utmost detail as much as I can at UG level, but if you are to talk about the research is endless. The sky is the limit in this particular topic. You cannot say that only this much is enough. Whatever you read is not enough if you want to read even further. Okay. Then primary, secondary, and tertiary messengers. I remember I have talked about this extensively. I've explained these messengers extensively during my live and recorded lectures earlier. The role of rank and Rankel complex in osteoprotein, osteoblastic, and osteoclastic activities. This also. Types of forces. Examples of continuous, intermittent, and interrupted forces along with the graphs. This is important. And accelerated orthodontics and role of pharmacology on the rate of tooth movement. What all pharmacological agents are there to increase the rate of tooth movement and to decrease the rate of tooth movement. Then accelerated orthodontics, we can have corticotomy, we can have lipus, we can have surgical means, we can have non-surgical means, we can have pharmacological means. There are many different types of accelerated orthodontic techniques which I have already covered in your live and recorded lectures. Okay, so you have to remember these particular topics from the main topic of biology behind orthodontic tooth movement. All of the following are secondary messengers in tooth movement except, now the question is asking about primary messenger. Calcium ions are secondary messengers. CAMP is definitely a secondary messenger. CGMP is also a secondary messengers, whereas prostaglandins are the primary messengers. According to pressure tension theory by Schwartz. It was given by Schwartz. Okay, Anand has asked me to explain translation again. Beta, what exactly do you want me to explain in translation? This particular figure? All right. So what I'm talking about, the amount of moment generated at the point of force application, right? The amount of moment generated at the point of force application, that is at the bracket slot, to cause translation, to cause bodily tooth movement, should be equal to the amount of counter movement generated, again at the bracket slot. That is why the MC to MF ratio should be equal to 1. It should be equal, no? The moment of couple and moment of force should be equal to each other to cause translation of the tooth. That is why in this particular figure, the MC upon MF ratio should be equal to 1 to bring about pure translation of the tooth. Okay, I hope I am clear. All right. Next question. Now this particular question again was asked in one of the AIMS exam, INI-CET exam. I don't know which year, but this was asked in AIMS exam earlier. Activity index means. Now I have also dwelled into deep searching. So I found one particular article for you, which is there on your screen, which was published in Archives of Oral Biology in February 2001. So this particular article says, actually that's the activity index means the relationship between the interleukin 1 beta and interleukin receptor antagonists in the gingival clavicular fluid. The level between them is known as activity index. Okay, I'll read it for you. So certain experiments were done. The gingival clavicular fluid cytokine concentration from experimental and control teeth were expressed relative to total protein in the GCF and compared using an activity index. So that means activity index means, let me highlight it for you. Activity index means experimental interleukin 1 beta upon interleukin 1 receptor antagonist upon control interleukin 1 beta and interleukin 1 receptor antagonist. So we are comparing the experimental values with the control values. So that is exactly what is the meaning of activity index. Okay. So activity index is a relationship between the interleukin 1 beta and interleukin receptor antagonist in the gingival clavicular fluid, not in the saliva. So you have to remember this, in the gingival clavicular fluid, GCF. Next topic is malfunctional appliances. In this you have to remember the general principles, the modus operandi of different malfunctional appliances, principles of force application and elimination, then little bit about history, name of the inventor, activator, types of activator, then the bite construction or bite registration, what you call. Then comes VTO, the visualized treatment objective. Then talking about bionator, again history, the name of the inventor, types and the indications. Again, what is the modus operandi, how the tongue affects, how the tongue modulates, how the bionator helps in modulating the position of the tongue, which in turn modulates the development of class 3 or class 2 malocclusion. So it's concepts like that you have to remember. Then twin block is one of the most important malfunctional appliances. History, again, name of the inventor, what are the indications, what is the philosophy behind, what are the types and the modifications. Then Frankel plans, types and the indications. We have a table in your textbooks, whatever textbook you refer for orthodontics, most likely Balaji, Gurkirat Singh, Sridhar Prem Kumar. So you have the different types of Frankel plans and the indications, and bite registration I told you about. So these are the different topics, subtopics you have to remember, you have to understand from malfunctional plans. For bite registration in mandibular advancement, which of the following statement is correct? A small increment of mandibular advancement should produce a greater skeletal effect. So this is correct. Frankel strongly advocated the small advancement with minimal vertical separation of the jaws. This is also correct. In clinical practice, how far the mandible is advanced seems to make little or no difference in the response up to a limit of 7 to 8 millimeters. This is also correct. Hence, all of the above will be the correct option. Okay. Surgical orthodontics. Again, an important topic. Actually, this topic is an overlap between orthodontic and oral surgery. So, I being an orthodontist, I have taught about the orthodontic aspects of surgical orthodontics. Whereas the oral surgery faculty, Dr. Himani, must have talked about the surgical aspects of orthodontic surgery. So you have to know about the historical background. You have to know about the minor surgical procedures. We have talked about frenectomy, disimpaction, circumferential supracrustal fibrotomy, which is also known as precision or Edwards technique. Gingivectomy, the indication, contraindication of the techniques. Then major surgical procedures, you have to understand the general principles, different maxillary orthodontic surgery, different mandibular orthodontic surgeries, different adjunctive surgical procedures like genioplasties and all. Then this particular stability of hierarchy of surgical procedures and envelope of discrepancy, I would say these two are the most important topics in the entire chapter on surgical orthodontics. So there is a particular, in Profit, there is a textbook called Contemporary Orthodontics by William R. Profit. So that particular textbook is rightly known as the Bible of orthodontics. You know, we are Indians, we are Hindus, so I should say that's called Gita of orthodontics. No offense to anyone, sorry about that. So there is a particular figure given in the chapter on surgical orthodontics, and that particular figure I have also included in my lectures, which we have talked about earlier. So there is a particular hierarchy. So there's a particular hierarchy, how you go up. I mean, the maxilla is made up or the mandible is made forward or downward or expanded. That hierarchy of stability is given beautifully in that. So you are supposed to remember that hierarchy table by heart. By heart, when I say by heart, means by heart. Okay. Then envelope of discrepancy. This is again a topic to be understood properly. I've explained that earlier. So envelope of discrepancy means the amount of tooth movement possible by surgical treatment alone, orthodontics plus surgical treatment, or myofunctional plans treatment alone. So it shows an extent, the maximum extent of tooth movement possible by undertaking these different procedures. So you have to remember how much the tooth can be retracted, how much the tooth can be protracted, vertical movement, transverse movement. So all these things, all these numerical values you have to remember. And then you will be asked certain application based MCQs on specific case requirement. Example, the orthodontic surgery commonly carried out for mandibular prognathism class 3 is sagittal split osteotomy, also known as bilateral sagittal split osteotomy, BSSO. That is the most common surgery carried out for correction of mandibular prognathism. Genioplasty refers to insertion of a plastic material within the soft tissue of the chin to increase its size. Surgical procedure which alters the shape, size or position of the chin in all three dimensions of the space. You can see the figure on the right side. That's exactly what the second option is. Gene therapy to reduce the tendency to develop a malocclusion. Now this option C and D are like they are out of the context. They have just inserted, the exam setters have just inserted these two options just to confuse you. Genioplasty, gene therapy. Sounds similar, no? But you don't have to get confused. You have to remember what is genioplasty. Genio means related to the chin. It has got nothing to do with the gene therapy. Okay? So option B, that is surgical procedure which alters the shape, size or position of the chin in all three dimensions of space is the correct answer. Next is orthodontic biomaterials. Again an important topic. So you will be asked question on stainless steel, stress strain curve, phase transformation, austenitic, martensitic, ferritic. Nickel titanium, this is an important topic. Concepts of superelasticity, shape memory, phase transformation between austenitic and martensitic, which is dependent on the temperature and as well as on the deformation, compressive and shear stresses. Then one more topic related to the nickel titanium is twinning. I've explained about twinning in night eye in my lectures. You are most welcome to ping me on WhatsApp if you're not able to understand that. I'll explain that again. Then beta titanium, composition, indications, which is the most formable material, which is the most formable wire. This is the most formable wire. Then load deflection rate, certain MCQs on the load deflection rate as well. Then the concept behind or the definitions of formability, resilience, fracture toughness, proportional limit, ultimate tensile strength, and certain orthodontic auxiliaries like magnets in orthodontics, like elastics in orthodontics, band material, then bonding material in orthodontics. So all those things you have to be well aware of. Wires, also called shape memory wires, are which ones? Nickel titanium wires. Okay, so this particular graph I have included in this slide is called a stress strain curve illustrating superelasticity due to the stress induced transformation from austenitic to the martensitic phase. So what is being shown here? So nickel titanium at the room temperature, or if it is not deformed, that is present in the austenitic phase. Once you start inducing stress, once you start stretching it, once you start inserting it into the crowded dentition, I mean the brackets are placed onto the crowded dentition, and these wires are inserted into that bracket slot. So from B to C we have phase transformation, and finally austenite converts to martensite. And as soon as you release the stress, the martensite starts to get converted into austenite again. So the martensite, upon release of the stress, the austenite gets converted back to, the martensite gets converted back to austenite. So this is a very specific phenomena which is uniquely present in nickel titanium wires, and this is what is known as superelasticity. Okay. Interceptive preventive orthodontics. Molar discalization, various appliances can be asked as image based questions. I've been talking about certain image based questions earlier. Many appliances are there. So you have to remember few of them properly, diligently. You don't have to get confused. Exam setters are there to confuse you. The entire world is there to confuse you. But if your core concepts are strong, if they're solid, I'm telling you, no force in the world can confuse you. Alright? Then methods of gaining space, habits and the interception, arch expansion, extraoral orthopedic appliances, headgear, face mask, chin cup. Headgear and its biomechanics. This is again important. application and clinical based scenario MCQs will be asked. Okay, and finally space maintenance from preventive orthodontics can also be asked. Now I have included one MCQ which was asked in NEET MDS 2024. Which of the following is a sadomasochistic habit? Now before answering this, we have to understand what is the meaning of sadomasochistic habit. So according to Wikipedia, self-inflicted oral mutilation, that is masochistic habit, is defined as a deliberate harm to one's own body without suicidal intentions. Without suicidal intentions. So deliberate harms to one's own body. Okay, that is the meaning of sadomasochistic habit. Now there was a small controversy in this particular question, since these questions are all memory based. The questions which are presented to us, they are all memory based. So I don't know whether lip biting was there in the options or not. I don't know whether lip biting was there in the options or not. If, please listen to me carefully, if lip biting was there in the options, without any doubt, lip biting would have been the correct answer. But certain students said that lip biting was not an option. So what should be the correct answer? If lip biting is not the answer, tongue thrusting is the second best answer. Okay? So D is greater than A. I mean, D is a better answer than option A. Now, what is the meaning of frenum thrusting? That also I've included here. If the maxillary incisors are slightly spaced apart, the child may lock his or her labral frenum between these teeth and permit to be in this position for several hours at a stretch on constant repetition. This may turn into habit which may displace the teeth even further apart. That's the meaning of frenum thrusting. So that is not a very important thing to remember, but the only thing you have to remember in this particular topic, in this particular MCQ, is the meaning of sadomasochistic habit. Why does it happen, and what is the best example of that? To conclude today's session, just as a footnote, the MCQs books to be read specifically for orthodontic subject. So nothing like it if you read Jitendra Sharan. It's an excellent collection of, I would say, more than how many? More than 6,000, 5,000 MCQs, if I'm not wrong. Excellent textbook. Dental Pearls, everybody must be reading. Neeraj Wadhwan, everybody must be reading. Prabhakaran, Ritu Duggal. So the orthodontic and orthodontic aspects, orthodontic section of Neeraj Wadhwan, Prabhakaran and Ritu Duggal is important. Certain MCQs, certain straightforward MCQs are asked, I have seen, which are asked from Prabhakaran and Ritu Duggal books. And if you're really serious about cracking NEET exam or INI-CET exam, I will sincerely recommend you to get hold of National Board of Dental Examination question banks, NBDE question banks. If you cannot get hold of it, ask me. I have a collection of them. I will mail you. Just ask me. I'm there to help you out. Okay? So that's it for today. I hope you people enjoyed today's session. If you have any doubts, you know where to find me. And always remember, don't settle, don't stop. Let me see if I have any question. Nikesh Maheshwari has asked me, sir, temperature reduction also leads to Martensite to austenite. Yes, correct. I told you in the beginning, no? I told you that the transformation, the phase transformation from austenite to Martensite, that happens in two ways. Either by load or by temperature differences. So whenever you cool the Martensite to austenite, whenever you cool the nickel titanium, I mean, the Martensite is converted back to austenite, and whenever you heat it, the austenite is converted to Martensite. Okay? Alright, so let's call it a day. All the best. Stay happy. Stay well. All the best. Take care of yourself.